So now, let's move from the lived experience to the systems that shape visibility. Dr. Atul from Tata Memorial Hospital takes us inside India's population-based cancer registries, exposing the cracks where patients disappear and data falters.
Hi, hello everyone. I am myself Dr. Atul Budukh. I am working as a professor and officer in charge for medical records and cancer registries in the hospital called Tata Memorial Hospital in Mumbai, India. I am also responsible to support the cancer registries from Southeast Asia through International Agency for Research on Cancer Registration Regional Hub. I will present my presentation on colorectal cancer in India. What are the challenges we face in data collection, treatment completion? Thank you very much, Henley, for inviting me for this wonderful meeting. So I'm going to present the work on colorectal cancer registries and reality from India. And the meeting all counters in data, dignity, disturbance in global cancer equity, global colon cancer association. Background: population-based cancer registries are important tools for cancer control. Having good data about disease burden makes a planning for disease control more effective. Population-based cancer registries are excellent source for data on incidence. However, there are several challenges in establishing operating population-based cancer registries, especially regarding data collection. Tata Memorial Hospitals, we have 12 population-based cancer registries in different parts of India. And we find it very difficult in establishing the cancer registries because there is lack of awareness in the government side also, as well as the private hospitals refuse to share the data. There is no trained human resources. Staff sustainability is also one of the challenge, and the poor death registration is also one of the challenge in establishing the population-based cancer registry. If you see the India, this is the India map. We have crossed 1.4 billion population. And if you see India, we have only 52 population-based cancer registries. And the population covered by India under the population-based cancer registry is 19%. Only 18.6% of India's population is covered by the registries. And more than 80% of India's population, especially rural and tribal regions, is underreported. If you see the hospital-based cancer registry, we have 341 hospital cancer registry. The National Cancer Registry Programs, who runs by Indian Council of Medical Research, they regularly collect the data from PBCR and HBCR, and it is publicly available. The reports are publicly available by the NCRP. If you see the colorectal cancer burden in India, the colorectal cancer burden based on the 43 population-based cancer registry data that is got published in JAMA network recently. And what we observed that around 84,000, more than 84,000 colorectal cancer cases occurred in India every year. And the rate is 6 per 100,000. This is crude rate. And the mortality is 50% is the mortality is 3.2. Mostly the incidence of colon and rectum is almost same. There is no variation in the incidence. It is around 3.4 to 3.2 per 100,000. And female cancer incidence is low compared to the male incidence. If you compare the colorectal cancer burden with other parts of Europe, US, Brazil, Germany, and other parts, the risk of getting colorectal cancer is very low. The risk is very high in Spain, 1 in 24. Italy is 1 in 29. United States of America is 1 in 34. We have high number because of large population, but the risk is low as compared to the US, Europe, and North American countries. If you see the incidence, European countries' incidence with the India, it is 7 to 8 times European countries' incidence, and United States incidence is high as compared to the Indian data. India, if you see the colon cancer, the rate is 5.7 as per Globocan, and in female it is 3.4. And if you see the Spain looks very high in Europe, and in United Kingdom, female incidence is very high. When we put the colorectal cancer incidence in all the geographies of India as per the population-based cancer registry, Northeast India parts showing the high incidence compared to other parts of India, like Western India and rural parts of India, the rates are low. But the country, the region like Mizoram, Northeast is showing high incidence rate because of lifestyle, more alcohol, more tobacco, and more meat. The lifestyle, the diet. That is one of the risk factors for the colorectal cancer. If you see the incidence of rural India, like Sangrur, the incidence is very low. Varanasi also, we have this is 50% registries urban, 50% registries rural. It shows low incidence rate. We have put the incidence rate in the map of India. The Northeast India has the highest rate. The lowest is 2.4, to range is highest 11.9, and female it is 1.9 to 9. If you see the Central East region, the incidence is 2 to 4, and female it is 1 to 4. South region showing high incidence 3.4 to 10.9, mostly from the Tamil Nadu area there. And females it is 1.9 to 7.3. West region it is showing 2.4 to 7.3, and female it is showing 1.1 to 5.7. If you see North region, the rates are also low, 1.9 to 6.8, and females 1.1 to 4.8. And if you see the urban-rural difference in the colorectal cancer incidence within the India, the rural area incidence is low. If you compare the rate ratio of the Maharashtra state, Punjab state, Tamil Nadu state, and Northeast state, the rural-urban ratio is more than 2 point. And only in North it is 4.7, and it is statistically significant both in males and females. The rural area rates are low. The RC registry is rural registry, which is showing low rate as compared to Mumbai. If you see the Punjab, the Sangrur, the rural area is showing low rate compared to urban area. Similarly, in Tamil Nadu, the Chennai is showing 9.10 incidence rate, and Dindigul is showing 3.9. In the same state, the rural urban. And Northeast, the Kamrup urban is showing 11.3 rate in male, and Tripura is showing 2.4. Similarly, it shows in the female. So rural area rates are low compared to urban area, and it is statistically significant. This is the analysis based on the published data in the cancer incidence in 5 continents by International Agency for Research on Cancer, WHO, Lyon, France. If you see the incidence rates of colorectal cancer, the global cancer observers suggest that the colorectal cancer incidence and mortality shall double by 2050, what present is, and it is showing annual percentage change 2 to 3% increase from the past 2 decades. You can see the trend, it is increasing trend from 2003 to 2017. And age-specific incidence rate, you can see that the straight line, as the age increases, the risk of getting cancer is increases in both colon and rectum cancer. If you see the histopathology of colorectal cancer in Indian hospital registries data from the hospital-based cancer registry, what we can see is 93% colorectal cancers were adenocarcinoma, and we get very few cases of squamous cell carcinoma, neuroendocrine tumors, and other tumors. And you see the staging of the disease. Staging of the disease from the hospital-based registry. Very few cases comes at the localized stage, and most of the patients comes at the loco-regional or distance metastasis. If you see, over 45% of colon cancer and 55% of rectal cancers were diagnosed at the loco-regional stage. And one of the challenges is for the patients to reach to the treatment centers. If you see India is a large country and most of the cancer centers are in the urban area. People has to travel long and hospitals are overloaded. It's difficult to get the appointments of the doctors, long waiting queue in the hospitals for the diagnosis and further treatment. And patient has other social and financial challenges to reach to the hospitals. If you see the survival, as per the Sarukan, the survival is extremely low. One of the reason is the patients reach at the locally advanced stage or at distance metastatic stage, and they face lot of challenges in treatment completion. The survival shows is 34% for 5 years for colon cancer and 38% for the rectum cancer. This is based on the data from the Sarukan. And 5 year relative survival in USA it is 65%, England it is 58%, which is very high as compared to the Indian registries. We are supporting the rural hospitals in R&D where there is a good doctors and it's in Pune. The 5 to 10% of did not undergo therapy and the cancer hospitals in R&D. About 61% of patients has completed the treatment and our remaining has left the treatment in between. We have another center in Chipro in the Maharashtra. It is rural area near Mumbai. 43% of colorectal cancer patients complete their treatment. And the difference in the treatment could be possibly due to higher uptake of government health schemes in the R&D hospitals. R&D hospitals, they have very good government schemes implemented. And it is close to the urban area also, though it is rural, it is just 30 kilometers from the main city. So what are the observation in all the cancer registries we observed that patients are reaching to the hospital and they need some accompanying person, some patient navigation services are required, and they need continuous counseling. What is the disease status? What is the treatment protocol? How much times they are required to stay in the hospital? And what are the care need to be taken after the treatment is required. I'm showing you one center of Tata Memorial Center, which is in the rural parts of Punjab. And you can see the difference. The Sangrur is the main place. Before our hospital is to come, patient is to travel to several places like Amritsar, 200 kilometers, Faridkot, 131 kilometers, Batinda, 97 kilometers, Rajasthan, they go to treatment of 400 kilometers, Delhi. So patient from rural area has to travel long to complete the treatment. This is the challenges we observed in the rural area of the India, as most of the cancer treatment centers are in the urban area. What are the challenges we face in data collections? One of the challenges is non-cooperations from the data sources like private hospitals. When population-based cancer registry, the objective is that we have to go to all the hospitals to collect the data. And there is a lot of reluctance from the private hospital to share the data. Low awareness about the cancer in the population. People doesn't know the proper signs, symptoms, and preventive measures. They mostly reach to the hospital at late stage, and some of them goes for the alternative treatment. Lack of modern infrastructure, poorly maintained medical records. You can see one of the medical records room. It is always manually maintained in several public hospitals, though government has encouraging to have an electronic medical record. But presently we face a lot of challenges. We have to go to the manual record system. If we found one patient, we have to search many records to get the final data set of the patient. Sometimes we may not get the proper demographic information also. Sometimes we may not get the staging information also. So we have to communicate with the treating consultant what treatment has been provided to the patient. And when disease is at advanced stage, doctor recommend a palliative treatment. Patient prefer to go for alternative treatment when disease at advanced stage, and we don't get the data of such patients. This is one of the challenges we have noticed in the population-based cancer. In hospital-based cancer registry, lack of electronic medical records, incomplete or inaccurate medical records has been observed. lack of trained personnel. Most of the people are busy in the OPD, IPD, and handling the patient flow. So they don't have a trained human resources to maintain the hospital-based cancer registry. Difficulty in integrating different data sources. We have to see all the departments to integrate the data source. High caseload, staging data is not properly maintained, and difficulties in cooperation from the medical and paramedical staff that is noted in the running the hospital-based cancer registries. And we have the lot of good studies done from the Indian researcher. And what are the risk factors for the cancer, colorectal cancer based on the dietary habit? So what we observe that beef, eggs, mutton, red meat, processed meat, the risk is high compared to other parts, other normal patients, normal visitors in the hospitals. This is the case control study as reported that the beef, egg, mutton, red meat, processed meat are the risk factor for the colorectal cancer. What does the International Agency for Research on Cancer say? The group 1 carcinogens to humans are alcohol, processed meat, tobacco smoking are carcinogenic to humans. Group 2A probable carcinogens are red meat, night shift work, firefighting as an occupation, and asbestos exposure. X-ray and gamma radiation is mentioned within the group 1 for colon cancer, but for that group 2 is for rectal cancer. This is the IRC list of the carcinogenic items. That is group 1 carcinogenic and group 2 AR probable carcinogenic. Our group has done a study on epidemiology of colorectal cancer. And what we observed that in going through all the literature, we have prepared a presentation, we have published a report on epidemiology of colorectal cancer, a review with special emphasis on India. What we observe is that alcohol, junk food, red and processed meat, family history of cancer, heredity syndromes and oncogenes, tobacco smoking, toxic exposure, infectious agent like HPV, H. pylori, HBV, comorbidities, obesity, diabetes, and inflammatory bowel disease are the risk factors. And what are the protective factors? And good for fruits and vegetable intakes is high, milk and dairy products, fish, physical activity, and the medicine like aspirins and vitamins, they show the protective factors in the colorectal cancer studies. What are the recommendations we have? To enable the primary prevention of colorectal cancer, risk factors, education of primary health centers, doctors, and health workers, followed by health education to common people is required. Promotion of consumption of balanced diet with high fiber intake, reduced red meat consumption, maintenance of healthy body weight, and curbing tobacco and alcohol use at the primary health center level. Considering the Indian situation, where incidence rates are not high and there are limited resources in the healthcare system, population-based mass screening for CIC not be the cost effective and is currently not recommended. What we recommend is that if personal history at risk, those with personal or family history of IBD, adenomas, CRC, and heredity conditions like Lynch syndrome must be offered opportunistic high-risk screening. And what is our experience says working in the cancer prevention program, if you provide effective health education program, preventive measures, and people should aware of this sign, symptom, preventive measure, and if they come across the signs, symptoms, and of colorectal cancer, where they should go for the treatment, for the diagnosis. And also, Government of India has started several health schemes. We need to raise the awareness of government-funded health schemes available in the hospital, so that there is be lot of dropouts will be controlled. As patients, if you see the hospital-based cancer registry data, 30% patients dropout is there, and there is social reasons. One of the reasons is financial reasons. So due to the health schemes, there is a lot of improvement in the patient treatment outcome, and continuous education programs are required for the medical officer, the treating consultant to maintain the good database. The directors of the hospital should focus on maintaining the good database, which is required for the research and the planning purposes, is recommended based on our experience working in the population-based cancer registry and hospital-based cancer registry. Thank you very much for inviting for such a wonderful meeting. Thank you, Global Colon Cancer Association, for inviting me for this meeting. Your questions are most welcome. Thank you very much.
Thank you, Dr. Budukh, for highlighting the urgency of India's data gap. Nearly 80% of the population isn't being counted. Even colorectal cancer continues to rise, and only 42.8% of the patients complete treatment. That's unheard of. That is just, it's awful to hear those statistics. Your insights on these barriers, from missing electronic records to incomplete data and limited hospital cooperation, reminds us that cancer data and equity is not just technical, it's human. So remember, I said at the very beginning, this is a very interactive Congress, so it is time for another poll. So in listening to Dr. Budukh's presentation, what types of cancer registries are you familiar with? Check all that applies: population-based registry, hospital-based registries, pathology-based registries, patient-led registries, or none. Choose which best fits you. Now let's see what the results are. Wow, we have a tie going on here, almost just a little bit, but we're doing well here. This is amazing. So hospital-based registries are leading the charge in most of your areas, followed by population-based registries. So we still have work to do. This is great, great information. Thank you so much for participating.